Good morning, everyone. I'm a consultant in emergency medicine at Glasgow Royal Infirmary, and I also work in Ward 46, where I'm a lead consultant there looking after head injury patients, which we've done for many years. I was asked to come along and speak to you this morning. I'd like to thank Kirsten for the invitation. And it's quite a broad audience, broad range of experience and expertise, so I've made the talk deliberately broad in its scope. We're going to speak this morning about the early management of head injury and the challenges that me and my colleagues encounter in looking after patients during this phase of the injury. I guess as a medic, we tend to look at the injury as the primary injury, and this is the injury that happens directly to the cells or the tissues in your brain as you get the impact or whatever the injury is to the skull and to the underlying brain tissue. And prevention has really been shown to be better than cure in this. A lot of the developments over the last 50 to 70 years, be it design of seatbelts, better car design, and kind of preventative measures to avoid people getting a head injury or a primary injury in the first place, have been the real areas that kind of have prevented and at a population level made improvements on this. And similar things have happened in sports and workplace areas with better helmets, better work awareness, safety, and better awareness of concussion, etc. in sport. But we're all here because we know that head injury does happen, and the effects can be devastating and can be lifelong. So how do we manage and how do we work through head injury as a health service, particularly in the initial stages, and take you from the accident scene or wherever this has happened to you through the emergency department and into the early phases of your rehabilitation? So really what all of that service and that setup is about is minimizing secondary injury. So the primary injury was where you had the blow to your head. And this is a slide that's often used in stroke medicine. So I don't have a pointer, unfortunately, today, but you can see in the middle of the screen that there's a round red circle. And coming off to the right-hand side of that, there's a red line, which is one of the arteries, which has brought blood from the heart to bring it up into the center of the brain to feed the brain tissue with the oxygen and the nutrients that it requires. When this blood vessel blocks or is damaged, you get tissue just downstream of that, which loses its supply of oxygen, and that tissue probably dies irreversibly, irrespective of what we do for these patients. Around that tissue, though, you see two other colours, a kind of bright orange and a darker red, and this is tissue that if you optimise and make everything right for this patient in terms of improving their blood pressure, improving their oxygen delivery, and making sure that there isn't any kind of ongoing injury, you can rescue as much of this tissue back, and then that allows you to rehabilitate your patient better. The risk is if you don't do your care properly, that all of that red and orange tissue will also become black, and then you lead to a much more devastating injury for your patient that's much more difficult to rehabilitate. This is a picture of the French military surgeon, Dominique Jean Barry, and he was involved in the military field hospitals for the Napoleonic Wars. And at the time, people were treated based on their military rank in terms of priority, but he developed a number of systems, including ambulances that went into the field to retrieve patients, but also developed a system whereby he realized that they were spending time looking after people who didn't need the care, and they could have redirected that care more appropriately and more effectively for a better outcome for more people. And the idea of triage was born, which the French word for sorting, and that's how we look at patients and deliver our care on a day-to-day basis. So when you phone or your bystander will phone 999 after your incident has happened, you'll be speaking with a call handler who will go through with quite methodical sounding questions, asking you, is the patient breathing, do they have a pulse, etc. And what they're trying to do is establish the facts around your injury. As they're doing that, they will be listening out for the story of what you're telling them, and then they will also be involving trauma teams, which will be specialised teams who sit next to them in the kind of call handling centre, and they can then activate a trauma team to go out to the scene of the injury to bring basically intensive care level support to the site of the accident. And this team is the retrieval team, and they are specialised paramedics and specialised consultants who deal in pre-hospital medicine and are used to working in these environments. And the idea or benefit behind all of this is it brings the best of care to the roadside or the injury, and it starts that care early and saves people worsening of their secondary injury. In the last number of years, Scotland-wide, there have been trauma networks established, and basically a trauma network, for which there's one in the west of Scotland, has a major trauma centre at the centre of it, and in Glasgow that's the Queen Elizabeth Hospital. What that is a hospital which has got effectively every team and every service that's required to look after head injury patients and other trauma patients as well. And they have much more concentrated facilities, they have much more capacity to deal with these patients. And then in addition to them, you have trauma units, which are hospitals like where I work in Glasgow Royal Infirmary or the Royal Alexandra Hospital in Paisley or Crosshouse. And they have fewer services than the major trauma centre, but would still receive trauma patients. So on a practical level, this is the tool that's used by paramedics and by pre-hospital staff at the scene of the accident. So their first intervention will be to assess your physiology. And this is difficult to read because of small print, and I don't expect you to see all of it. But they look at things like your blood pressure, your respiratory rate, and your level of consciousness. And if they are deranged out with normal limits, they will bring you to the major trauma centre because there's a suspicion that you have a serious injury which is best managed there. They then look at particular injuries, so things like penetrating injuries to the torso, open fractures of the skull, pulseless extremities or pulseless limbs after injury, and these are all also things that go to the major trauma centre. The trauma units, though, still see other trauma, people who fall from heights of greater than 20 feet, people who have been knocked down by cars, motorcycles. These will all still come to trauma units if they don't satisfy the first two criteria. And if none of those criteria are satisfied, you can be managed in any emergency department. So when you arrive at the hospital, if you arrive in the company of the retrieval team, you're usually brought into resus directly, and you're met by a team who will have been assembled to look after you and to give you the best trauma care. I'll come back to that in just a minute, but if you self-present or aren't needing immediate resuscitation, you'll go through triage, and this is going back to the days of the Napoleonic Wars, where the nurse will take your history, and basically in that history they're looking to see what the mechanism of injury that you've suffered was, to see what risks you might have for ongoing brain injury, and then to kind of assess and decide how urgently you need to be put through the system. They will again measure your vital signs, check that your heart rate is okay and that your blood pressure is adequate to deliver blood and oxygen into your brain, and also check your blood sugar to make sure that the brain has the immediate nutrients that it requires to function. They will do a thing called your Glasgow Coma Score, which is 3 parts, which I'll cover in just a minute. And they'll also be interested to know about your medications. So a lot of people these days are on medications for other underlying conditions, and the ones we're particularly concerned about are anticoagulants. So things like apixaban for atrial fibrillation or irregular heartbeats. These will all lead to more severe injuries because they cause bleeding, and we're more alert to these people presenting to emergency departments and try to prioritise them to get more early scans to work out what the injury is. There's a particular new kind of awareness in trauma that there is a silver trauma group as well, which is basically elderly, more frail people. And while trauma was kind of historically considered about high-speed road traffic accidents, high falls, there's been a realization that as people are elder and more frail, that they're more prone to quite severe injuries despite having relatively benign sounding mechanisms. So a simple fall in the home may lead to the same brain injury in an elderly person as a high-speed road traffic accident would take to deliver that same injury in a younger person. So based on your information and your observations, you're allocated a triage category, and that's category 1 for the most urgent and category 4 for the least urgent. The challenge in the emergency department, though, is that we in Glasgow Royal Infirmary at least will probably see between 10 and 20 arrivals per hour. We're often working at double what our capacity is intended in terms of the number of people in the department as opposed to the number of cubicles. And there are lots of other competing interests and injuries going on in the department. So there may be a cardiac arrest happening as you arrive with your head injury. Somebody may be getting resuscitated from an overdose, etc. And there's just large crowds of people involved in delivering that care and looking after these patients. Another common issue we face is exit block in the emergency department, and that's when the hospital is full and is no longer able to accept patients up to the wards. And in that situation, all the people that we have already seen and treated stay in the emergency department, and we have to continue to look after them as well as all of the new arrivals that are presenting. Staffing is never as good as we would like it to be, and then if we have any complications with that staffing in terms of sickness or inadequately staffed posts, we're just not able to deal very quickly with that surge in capacity when it happens. And as I sit in the emergency department in charge and look at the screen to try and work out who to see first, wondering who has the early stages of a head injury that I can intervene and how I can fish them out of the queue and get them to the front is one of the biggest challenges. Practically speaking, what we do is we reassess these people repeatedly, recheck their Glasgow coma score, go over their history and flag them as urgent, and then re-examine them to see if we need to intervene. So some of you may wonder what the Glasgow coma score is, and this is a slide taken from YouTube called Geeky Medics. It's 3 parts to it. So you assess people's eye opening, which is relatively easy. Everybody scores 1 point for each parameter, so 3 is your minimum score in the end, and the maximum score is 15. People who are sitting with their eyes open score a 4. People who open their eyes when you speak to them will score a 3, and people who react to a painful stimulus by opening their eyes will score 2. And by a painful stimulus, we very often just grip their trapezius muscle, which is just here at the shoulder, and give that a really firm squeeze for maybe 5 or 10 seconds to see if we can trigger a response. Another one to use is just on your supraorbital ridge or in your eyebrow, just press in there on a nerve, and that will also trigger a painful stimulus that people will react to. The verbal response is often difficult. If you read the print, it says orientated, confused, inappropriate words or incomprehensible sounds. And I think this is very often describes the population in a pub on a Friday evening. So alcohol and drugs do have a big effect on your verbal response, and it may be just that. And this is one of the other confounding things in emergency medicine, that we sometimes have to look past the alcohol and still suspect that somebody might have a genuine brain injury that we're missing. The motor response is a little bit more reliable, and we usually tend to ask people to stick out their tongue as a command. If they've had any spinal cord injury and aren't able to move their limbs, asking them to squeeze your fingers, etc., is going to be a confounding factor. But if they can stick out their tongue, then you can assess that they have a GCS of 6 for the motor response. Localizing to pain is where the patient will reach up and try and grab the painful stimulus and move it out of the way. Flexing to pain is where they make this posture, and extending to pain is where they make that posture, which is the most depressed of the motor points. We add all those together, and that gives us a Glasgow coma score, which can indicate the severity of the brain injury. And then how does the treatment work? So it needs to be organised, and in 1976 a man called James Steiner, who was an orthopaedic surgeon, was flying his private plane in America and crashed into a field in Nebraska. And this is where advanced trauma life support was really born. He was so appalled by the care that he and his family received both at the scene of the accident and in the local hospital where they first presented, that when he had recovered and got back to work, he sat down with colleagues to look at a system whereby they could organise a structure in dealing with these traumatic cases. And there have been various advancements on this since. Most medics will be sent on advanced trauma life support courses as part of their training. And it is criticised as being a little bit rigid in the way things are done, but we have modified it both in military and civilian kind of use since. So what does it actually say or tell you to do? It basically asks you to cover airway, breathing, circulation, disability and exposure are the ABCDEs of trauma care. By airway, we just mean is the airway or mouth open and all the way down into the lung, that air can move in and out, so oxygen can go in and carbon dioxide, the waste gas, can come out. We're then effectively looking at the patient's breathing. Are they taking a breath adequately, or are their lungs injured from bleeding, from collapse, from rib fractures, from chest injuries that are limiting the ability to breathe properly? And then circulation, we're looking at whether the heart is actually filling up and pumping blood into the lung to pick up the oxygen, and then pumping that oxygenated blood around to all of the organs in the body, including the brain. Disability is effectively a Glasgow coma score assessment, and then exposure is where we fully undress the patient and examine them for all injuries to make sure we're not missing anything else. And then if you look, DEFG stands for don't ever forget glucose. We always measure a glucose level in these patients. If you see somebody who's had a low glucose level, it can very often mimic stroke and coma, and just fixing the glucose level can regain your GCS as well. So in practice, a team will assemble, and an anaesthetist will manage the airway, a trauma surgeon will manage the assessment of the other injuries, the abdomen, the chest, and the team will work together to stabilise the patient, to get them scanned, and to work out where the injuries are. In the meantime, as it's a head injury talk, I guess all of it's about delivering oxygen to the brain. We need to maintain a normal blood pressure, and for that we need to make sure the patient's not bleeding somewhere else into another injury. We look to maintain a normal pressure inside the head, and that's the whole premise, I guess, of neurosurgical treatments, is to relieve those pressures so that blood can continue to come in and supply the brain. The brain is extremely sensitive to a lack of oxygen, and even a few minutes without oxygen will lead to death of that tissue. And if you remember back to that slide, we're trying to save and prevent the damage spreading in the injured brain. There's also a thing called the Monroe-Kelly doctrine in emergency medicine and brain injury, and that basically states that the brain is sitting inside a fixed skull, and there isn't really room for any expansion. So if you do introduce another clot or bleed into the brain, it will cause pressure and prevent blood flowing in properly to supply those tissues. Realistically, in terms of imaging, we're looking at a CT scan for people who present with a head injury. And in the big queue of people in the waiting room following their triage, we're looking at who needs the earliest intervention. It's relatively easy in the big trauma cases that come in, and we do a thing called pan scanning, where we run the patient through the scanner and give them a contrast or dye injection and see where that dye leaks out. As they go through the scanner, it takes various pictures, and we can see where it is leaking from blood vessels and know that that's where the injuries are and what needs to be targeted. There's another guideline that we use routinely called NICE guideline number 232, and that is the management of head injury. And that also gives us advice on who we should scan and when. But the ones that we are particularly interested in scanning are those on anticoagulants and those with a reduced GCS, and we would try to do that as soon as we possibly could. Again, we have a realization increasingly that silver trauma is more risky, and we're often now trying to prioritize these people who present with not very many signs of head injury, but who are on medicines to thin their blood, as they may be at risk of a slower bleed. And then after all of that, you may find that you don't need to do very much. You may just sit and observe your patient, admit them to the ward perhaps, and see how things go over the next few days. Or it may be a more alarming and urgent situation where they need to be what's called intubated or put under anaesthetic or on a life support machine, and that can happen in the emergency department and also happen at the roadside if the dedicated team go out to do that. Those people who are intubated or put on under anaesthetic will need to go to intensive care, and they may or may not need neurosurgery involvement as well. In the emergency department, we do anaesthetise patients. They will be then sat at about 30 degrees to maximise the amount of venous blood that drains from their brain to improve perfusion of their brain. We will use drugs to paralyse them so that they can't cough or trigger rises in their pressure inside their brain. And we try to normalise all of the salts and sugars in their blood, normalise their blood pressure, and treat any other injuries. There are drugs we can give to reduce the spread of a bleed in the brain called tranexamic acid, and there are other rescue drugs that we can use like mannitol if we think we need to buy a little bit of time before we can get a patient to a neurosurgical theatre. But in all of this, we need to think about what else is needing fixed. Is the patient bleeding from another injury? If you've been knocked down by a car, maybe your spleen has been damaged, and maybe that needs to be fixed before a brain injury can be fixed, because remember, we're trying to minimize the secondary injury. And sometimes you feel like you're working particularly in a trauma unit where you're not next to the neurosurgical unit, it almost feels like you're working on one part and the neurosurgeon is working on another, but it really is a teamed effort, and unless you can stabilize the patient, there's very little benefit to be had from immediate neurosurgery. A couple of signs for your interest, I guess more than anything else. This is somebody who suffered a base of skull fracture, and the base of your skull is kind of a diagonal line across from the kind of edge of your eye socket over the top of your ear and back to the back of your skull. And in this case, there's bleeding and probable cerebrospinal fluid leak from the patient's ear, and this is a sign of base of skull fracture. Looking inside the ear, you're looking at the tympanic membrane, or the kind of eardrum, which is normally translucent. You can see through it, and in this case it is a lot of black bleeding behind the ear, and that's from a skull fracture which has bled down into the middle of the ear, which you can see when you look inside somebody's ear. And this is known as Battle's sign, which is delayed bruising that comes on usually after a couple of days. Again, a base of skull fracture, you'll get non-tender bruising at the back of the head behind the ear. A couple of CT scans then. So this is a classic scenario of somebody who gets a blow to the skull, and in this scenario you can see on the left of the screen there's a kind of lens-shaped white area, and this is a bleed called an extradural hemorrhage. It's a relatively small-looking bleed, but it's having a pressure effect, and if you're more experienced in looking at the scans, what you can see is that the brain is being compressed slightly from right to left. This is a case that Liam Neeson's wife died from. So she had a blow to her skull, fell over while skiing, and then had what was known as a lucid interval. When she woke up from that first blow, she was alert, seemed orientated, and went back to her hotel room with everyone's approval just to have a rest, and was then found with a reduced Glasgow coma score, and unfortunately died of this injury and its complications. So this is your classic story of the lucid interval, where somebody may lose consciousness to begin with, and then they need to be observed and scanned to check that they're not developing this. This is a more graphic illustration of how that might work. So you can see on this screen on the left-hand side, you have a large amount of blood or clot outside the skull, which is the white ring all around. And then inside on the left-hand side of the brain on your screen, you don't have any of the black little folds or infolding of the brain, and what's happening here is the blood or the clot has squeezed the brain down to the point where all of that fluid has been pushed out of the space. And this is a similar scenario. This is frontal contusions, so somebody who often falls and has a direct blow to the front of their skull, or in this case, there's possibility of a blow to the back right of the skull, and then the brain ricochets around inside the head and causes bleeding on the front as well. Those lesions mature over the first few days, and very often these people get delayed complications as well. So even if immediate neurosurgery isn't needed, we very often have to watch these patients to look for delayed complications. And this slide quite graphically illustrates just what the neurosurgery idea is. So in this patient, you have on the left of your screen a part of the skull has been removed, and what that does is allows room for the brain to expand when it's swollen and damaged without causing pressure on the remaining brain tissue, which would then lose its circulation and become more damaged. So this is a rescue treatment, and then when the injury has been recovered from, the bone cap can be replaced. So then begins the rehabilitation phase after all of these treatments. And there is a little difference since the emergence of the trauma centres and the trauma network between the level of care you get in the trauma unit and the major trauma centre. We do have less resources, but we still have some successes. And I know some colleagues are in the audience who work with me in Ward 46. Our aim, though, in the trauma network is probably to begin to even up the level of service, and there is discussions and some work underway for this already. So in the trauma units, you're likely to be looked after by an emergency medicine team in Glasgow. The Royal Alexandra Hospital in Paisley and Glasgow Royal follow this model. In the Queen Elizabeth Hospital, you're probably more likely to be admitted first to critical care and then step down to a trauma ward, and there you're looked after by the head injury acute rehabilitation team and the head injury acute nurse practitioners. And they have developed a really specialised, impressive service where every aspect of head injury care is well looked after. On the trauma unit sites, it's a little bit more ad hoc. We access the same resources as the rest of the hospital. So if you go in with a stroke or any other medical condition, you'll get the same level of care as you would if you had a head injury, versus the major trauma centre where you'll have a dedicated team coordinating your rehab. The initial few weeks are often very, very stormy, and for those of you out there who have had a loved one go through this, it's often nightmarish, to say the least, to watch your relative go through this. They're often very agitated, they aren't feeding normally, they're not sleeping properly, they're confused, they don't seem to be remembering what's going on, and it can seem very hopeless in the initial stages. Over the following weeks, most people begin to settle down, and we then try to work as best we can to recover as much function as possible, but the earlier we can start the rehabilitation process, the better people will do. How it works in the trauma units is we then apply for specialist neurorehabilitation, and those people are seen by a neurorehab team from the Queen Elizabeth site, and then we apply to get them to a specialist brain injury unit like Graham Anderson House or Murchison Castle are the two we mostly use. So what would better care look like for us in the trauma unit? I guess we would ideally like to match the major trauma centre level of care, but realise that that might not be realistic. Better supervision for the people when they're first admitted overnight, and particularly in the early days with more high dependency care, would obviously be an improvement. And the appointment of a dedicated head injury nurse specialist to the trauma units would also massively improve care. I guess in terms of the first few weeks, it's the bread and butter, or the kind of day-to-day care is around physiotherapy and occupational therapy, and these people really make a difference in the care for these people and the rehabilitation journey that they go on. So the better we can deliver this in the early stages, the better the outcomes will be. The trauma network was launched with the tagline "Saving Lives and Giving Lives Back," and we would hope that if we could improve the rehabilitation side of things, we could then really capitalise on the improvements that have already been delivered in trauma care. Discussions, I guess, are in their infancy at the moment, and we're working to look at addressing this balance, but it's early days, and we will hopefully make some progress with this. I think in the future, trauma care will probably start to look a little bit different, and already in Glasgow Royal Infirmary, we are seeing that much more of our trauma care is silver trauma. And as the population ages and becomes more frail in general, I think more of that will be represented in general trauma. So that's the end of my talk. I'm happy to hand back the microphone to Chris and to take any questions. Thank you.
Thanks, Ty, for that really interesting opening talk. If anyone has any questions for Ty, could you raise your hands? We've got a microphone in the room. There's one there in the back corner.
Oh, that's it. Hi there, thank you for that. I'm from Murdiston Inpatient Brain Injury Rehab Service, and we've noticed a bit of a difference since the conception of the major trauma centre about the kind of inequality in the services for those who have traumatic brain injuries versus those who don't have the acquired brain injury. Is that something that's been kind of discussed at the acute side and kind of rectifying that?
I guess my discussions will be, because I only look after the traumatic brain injury, at least in terms of the ward that we run, we would be just making the argument for the traumatic brain injury side, and that's our kind of particular area of interest. But I think there's an argument which will probably need to be led by stroke and other services as well, as to how rehab can be evened up for those other patients with acquired brain injury as well.
I suppose it's also those who don't present with strokes, with your kind of anoxic brain injuries and things, who seem to be falling through the net, who don't fit into any of those pathways.
I think our first step would hopefully be to look at the traumatic brain injuries, but I guess a role for a head injury nurse specialist within a hospital would be to try and coordinate that rehab better. I guess in terms of the appetite for taking on a role, we probably need to be realistic and make the role smaller to begin with and then try and expand it up. But I know in the past there have been head injury nurse specialists who have worked in Glasgow who have delivered some of that care and delivered some of that coordination, which I guess these will be forgotten people in other wards who also are suffering from acquired brain injury, who aren't getting the same level of rehabilitation or care. But yes, it's a good point.
Any other questions for Ty?
Thanks, Ty, for such a clear and interesting talk. So you and your colleagues obviously are the front line of the entire NHS, and I know what pressure you're all under. What do you think would help? Is it about having more total resource? Is there something about public health education, about who should go to A&E when? What would help the services, do you think?
I guess the thing we all feel kind of slows us the most is the exit block. So having a hospital that discharges patients efficiently at the other end of their journey, which then depends on better social care, better long-term placements for patients who aren't able to go home. Things like guardianship applications cause huge delays in the hospital system, so improving that would make a big difference. I guess public health education about what should come to an emergency department is always useful, but that's stuff that we can probably divert away relatively quickly, and we have signposting nurses and nurses who work alongside triage colleagues who will redirect you away from the emergency department within the first couple of minutes. So we're not so much clogged up by that anymore. I guess over the last number of years, care has probably moved or changed, and if you go back 50 years ago, it was very much delivered by primary care, and that was seen as your main access to healthcare. But I think those days are long gone, and the emergency department has evolved to cope with that to some degree. I don't think we'll ever go all the way back there. It would be nice to wish for it, but I think realistically we can cope with what comes in, and it's often exit block is the biggest factor for us to cope as a system.
Thank you.
Is there any more? We've maybe got time for one more if there is. Okay, thank you.
Hi, thank you. That was really interesting. I was just wondering about what your sort of experience is with patients attending your service who maybe have a learning disability, or they've already had a brain injury in the past, where the sort of typical Glasgow Coma score indicators maybe wouldn't necessarily trigger for their baseline. I was just interested in how you would manage that.
Yeah, it's a valid question. We mostly usually rely on their carers or the people who know them better. So a Glasgow Coma score can only be taken to a certain value, and obviously we need to know what the person's normally capable of or what they're normally like. And then we take a view more on the change in the way their condition or how they're presenting on that particular day. So It may be that they have pre-existing problems or weaknesses that they wouldn't be able to demonstrate a normal Glasgow coma score. But if that's different to what they're normally like, then we would probably err on the side of caution and investigate and scan, etc. Yeah.
Thank you.
You're welcome.
Thank you, Ty. Could we maybe just have another round of applause for Ty? Thank you for his talk.